So then, so we screened the patient, and we identified that the patient is reporting some kind of thoughts, images, or urges, um, and we think that this person might have OCD. What about differential diagnosis? So one of the readers said that it's sometimes confusing, especially in children. It can be a little bit confusing if the person is not clearly describing obsessions or obsessive rituals due to OCD. They may be doing some kind of thing that may be actually a tic, or maybe, or like children with autism spectrum disorder might be doing stereotypical movements, and they are not giving a clear description. Any thoughts about like how to identify true OCD versus things that look like OCD?
Exactly. That's a great, great question. Because not everything that's compulsive or not everything that's obsessive is OCD. And we use the word obsessions and compulsions now quite routinely in a daily discussion, right?
Yeah.
But
Yeah.
it's not, it's a very important thing. So those of us who have worked with many OCD patients, we know that people with true OCD have always obsessions as well as compulsions. So they have both of those things because obsessions make the distress go up and compulsions are aimed to reduce the distress. They always have something that is both an
Right.
obsession and a compulsion. And what's really interesting is that they functionally related. So somebody
Yeah.
who's washing is almost always going to be something about contamination.
Yeah.
And someone who's checking is always going to be about either harm or fear of forgetting or something like that. So there's
Yeah.
a functional relationship between the obsessions and the compulsions. Now,
Excellent. Yeah.
many people have obsessions only. So there's rumination, there's things that somebody is obsessed with, they're doing, and they have to search and look and keep their mind on it, but they're not doing compulsions,
Yeah.
not OCD. There's the other, which is a lot of people do compulsive behaviors. There's compulsive shopping, compulsive eating, maybe even self-stimulation, movement in maybe autism or stuff like that, but it's not related to an
Yeah.
obsession easily.
Yes.
Now,
Yes.
it's possible that in autism there's some obsessions, but we don't know about them because they're not articulating them. And in order to do the treatment behaviorally, we do need the client to recognize the fact that there's compulsions and obsessions.
Yeah.
And so that we can work with obsessions and compulsions at the same time, because
Right.
that's where the treatment really is effective.
Very good. So you're saying that if we once we understand this concept that the obsession leads to a certain tension and distress, and there is some form of compulsion that is the solution, then this model will help us to differentiate. If we see
Right.
the person doing something, if I'm just scratching my nose, but there's no obsession behind it, then it's a mannerism of some kind. But
Mannerism or compulsion. And then let me just say something about children, because in children, we really have a little bit of a harder time, and they have a harder time identifying obsessions. And lots of children's behaviors look like a compulsion, or lining up your cars and things like that. The way you can tell something is OCD, though, is in many ways. So it's a developmental. So if it doesn't change developmentally, so the child continues to need to do that, or that their reaction is extremely strong when disrupted. So
right.
it's the severity of the reaction when
Yeah.
a compulsion is not adhered to. And many children get identified with ODD, for example, oppositional defiant disorder, when really what they have is OCD when the compulsions are not adhered to. So there's a lot of misdiagnosis in childhood.
Yeah.
We get people with a attention deficit disorder that actually have OCD. We get people with ODD who actually have OCD. We get people with other conditions that are thought of. And in teenagers, we get people with all kinds of diagnoses about their sexuality and things like that. It turns out that has actually got to do with OCD rather than with identity issues necessarily.
Right. Okay. So the child might not describe the obsession very clearly, but another thing to see is like what if they are if that behavior is not allowed, or they are we try to persuade them to not do that behavior.
Right.
Although that there may still be confusion with the rigidity. The children with autism spectrum disorder tend to have a lot of rigidity and don't like any deviation from their behavior. That might be a little more tricky, right?
It could be tricky, but in OCD, which is really interesting, the rigidity of the compulsion is in only in certain areas, not in all areas. So it's not encompassing. And
Right.
in what I understand from working with some of my colleagues who work with OCD and autistic children, there's some of the rigidity is blanketed. So it's
Yeah.
over all kinds of things, not just the content of the OCD. And this is what is also helpful, which other areas of their lives they're totally flexible about, but these
Yeah.
ones they're very sticky. And that
Very
tells
nice.
me it's probably more OCD than anything else.
That's an excellent, in a very simple way, you clarified the difference between the two things. That was very helpful. Thank you.
And let
So
me just say one more thing about children. When we see something that we see is a little bit of a strong reaction to change in situation, when there's sort of a ritual is not adhered to, I always tell parents, even if it's not OCD, let's teach them about flexibility. And if they can learn about flexibility, we've already kind of prevented some issues in the future, and we've taken away possible fodder that the OCD would have otherwise. And so the parenting of it is also important.